Dear students, your today's topic is edema, syndrome, edema, glomerulonephritis. What is glomerulonephritis? It is acute primary glomerulonephritis is a diffuse bilateral toxic immunological damage to the glomeruli manifested by impaired renal blood flow, characterized by oligoanuria, hematuria, proteinuria, increased blood pressure, edema, occurring cyclically, usually ends with recovery within a year. Chronic primary glomerulonephritis. It is acute glomerulonephritis that has lasted more than 1 year, characterized by a persistent clinical and morphological substrate, processed with periods of exacerbation and remission, with a possible outcome in a secondary wrinkled kidney and chronic renal failure. Risk factors. Glomerulonephritis is often processed by bacterial infection, including streptococcal, viral infections, including hepatitis B virus, viral and bacterial infections, hypothermia, the presence of chronic foci of infection, vaccination, administration of protein preparations. Glomerulonephritis manifests itself 7, 14, and 21 days after the onset of infection. Classification of primary glomerulonephritis in children. Forms of glomerulonephritis. First is acute glomerulonephritis with nephritic syndrome, with nephrotic syndrome, with isolated urinary syndrome, and with nephrotic syndrome, hematuria, and hypertension. Chronic glomerulonephritis. Nephrotic form, mixed, and hematuric. Subacute form of glomerulonephritis includes malignant glomerulonephritis. Clinical and laboratory diagnostic criteria. For hematuria syndrome, swelling is small, mainly on the face. In the oliguric phase, they can be pronounced with localization in the lumbar region, lower extremities, anterior abdominal wall, pass quickly, are associated with a decrease in the filtration capacity of the glomeruli and water retention. Blood pressure rises slightly, 15-20 above the age norm, short term for the period of oliguria due to hypovolemia, rarely the development of hypertensive encephalopathy, eclampsia manifested by convulsions, acute impairment and loss of vision, glomerular erythrocyturia of varying severity from macrohematuria, urine of the color of meat slopes, to 10-15 erythrocytes in the field of view, can persist for a long time and decreases gradually. Proteinuria is small, 1 gram on liter, or absent. Aseptic form, eosinophilic, lymphocytic. Leukocyturia more often during the period of oliguria. Nephrotic syndrome, clinical and laboratory symptom complex. Proteinuria over 2 or 5 gram on day in 1 day, or 50 milligram on kilogram. Hypoproteinemia, hypoalbuminemia, edema, hypercholesterolemia, hypercoagulation, electrolyte disturbance. For nephrotic syndrome, massive edema not only on the face, but also abdominal. Ascites, anasarca during the formation of edema. Oliguria is expressed, swelling is stable, growing within a few days. The appearance of edema is associated with hypoproteinemia and a decrease in oncotic pressure. Blood pressure doesn't change, less often in the period of oliguria. There is a moderate short-term hypertension. Proteinuria significant up to 3 to 20 gram on liter. Erythrocyturia, glomerular, small up to 10 to 20 per field of view, more often in the first 10-14 days of the disease or absent. Aseptic leukocyturia, with a predominance of lymphocytes and eosinophils, and cylinderuria, changes go in parallel with proteinuria. And with mixed syndrome, edema of varying severity from pastosity of the face to widespread, with water salt disorders, hypoproteinemia, arterial pressure is significantly and persistently increased, as a rule accompanied by the development of angionephropathy. The process is malignant, unfavorable. Proteinuria is pronounced, often non-selective, more than 3 grams in one day. Erythrocyturia, aseptic like leukocyturia, cylinderuria, granular, hyaline, waxy, sometimes terminal, unusually wide cylinders, less often cellular. There are features of the clinical picture of nephrotic syndrome with glomerulonephritis in children. Signs and peculiarities. Signs: the onset of the disease, more often gradual with increasing symptoms. Main manifestations: oliguria, edema, normal or elevated blood pressure. Respiratory system: in some patients with a rapid increase in edema, interstitial changes and pulmonary edema are possible. In the cardiovascular system, muffled tones, tachycardia, bradycardia. In the first days of the disease, an unsharply pronounced increase in blood pressure are possible. And gastrointestinal tract: in the first days of the disease, often nausea, vomiting with electrolyte disturbances, azotemia. And urinary system: sometimes positive symptoms of effleurage. The period of extrarenal manifestations is that lasts at least 2 weeks. Remission period and subsidence period. Diet therapy for nephrotic form of glomerulonephritis. Diet: in a serious condition with severe oliguria, edema, and azotemia within 3 and 4 days. Protein and salt restriction. Foods containing carbohydrates and fats are recommended. Allowed cereals like rice, buckwheat with butter, sugar, jam, vegetable soup, vegetable puree, croutons, lemon with powdered sugar, fresh fruits. Liquid by diuresis. When the condition improves after 3-4 days, or the condition is of moderate severity from the first days within 3 or 4 weeks. Table 7a with salt and protein restriction. Decay period: with the improvement of the condition from 4-5 weeks from the onset of the disease. The diet expands first week, second week, third and fourth. Drug therapy for glomerulonephritis. Period maximum activity from the first 6 days. Antibiotics, penicillin or cephalosporins. From the first 6 days, first generation antihistamines. From the first days of illness, antiplatelet agents and angioprotectors, anticoagulants. From the first days of illness, diuretic drugs like Lasix, furosemide. During maximum activity, glucocorticosteroids, prednisolone or methylprednisolone, but others may be used. Drug triamcinolone, dexamethasone, betamethasone, and pulse therapy with glucocorticosteroids is appropriate in individual patients with hormone dependence or resistance, can also be carried out at the first attack of nephrotic syndrome. If it is not possible, get remission. Treatment of chronic glomerulonephritis with hormone resistance and hormone-dependent glomerulonephritis with frequent recurrence, usually after a biopsy kidneys, depending on results. Morphological research. Cytostatics are usually prescribed along with glucocorticosteroids at a dose of 1.0 mg on kilogram every 48 hours. Cytostatics like cyclophosphamide, cyclosporine, etc. Cyclophosphamide. It is the end of your lecture. Thank you for your attention.